I'd like to welcome everyone this morning or this afternoon, depending on where you are, to this discussion on using history and science to anticipate the future. The COVID-19 pandemic, as we all know, has altered the social, personal, economic, and professional fabric of the global community. And the future is more uncertain than at any time in living memory. Healthcare is both more critical now and more fragile than ever. This panel will bring together some of the world's leading experts in their respective fields to help us better understand what may lie ahead for global health and to help us prepare for that uncertain future. Rather than prepared presentations, we've asked this panel to respond to questions that have been solicited from leaders in infection prevention and control, and we have allowed time for you to submit questions so that you have an opportunity to tap this expertise. I encourage you to take advantage of this unique opportunity. I'd like to start with a question for Arnaud. One of the challenges that we face in ending this pandemic is the development, manufacturing, and distribution of safe and effective vaccines. You and your position at the World Economic Forum have written and spoken about this topic extensively, and we would really appreciate some of your thoughts about this as we move forward.
Thank you very, very much, Don, and thanks to the OSAP organizers for getting me on that panel today. Thanks to Henry Schein team. I see many friends on the video, and particular thanks to you, Stan. So I think why is the World Economic Forum and vaccines? I think it's a long history. I think if you look back 20 years ago, the World Economic Forum was the place where the Global Alliance for Vaccination and Immunization was launched, Gavi. It's an organization that at this point in time, 20 years later, has raised more than $10 billion in pledges and support from various governments, and has been able to vaccinate 700 million children and arguably averted the death of more than 10 million kids. So massive vaccination campaigns. And that was one of the first public-private partnerships that emerged from our healthcare platform back to 2 decades ago. More recently, the forum was leading the charge after the Ebola crisis was raging in West Africa, sorry, and we were able to mobilize a number of private sector partners, governments, and large philanthropic organizations such as the Gates Foundation to actually create the Coalition for Epidemic Preparedness Innovation. And CEPI has been in existence since 2017. It was launched in Davos in 2017 and is currently running on a budget of $2 billion annually, currently incubating 9 vaccines candidates in the fight against COVID. And like you introduced that so well done, I think until the vaccine will be made available to humanity, I think we will live in the world of isolation, massive testing, contact tracing, and we will see progress. We've seen emerging tests, some of them being actually distributed by Henry Schein, go into the direction of antibody testing or rapid diagnostic testing that are probably going to be far less expensive than current PCR methods, and particularly referring to antigen tests being introduced by some of our partners actually as we speak. Now, in the field of vaccines, it's a mixed bag, and it's not necessarily a pretty story, I need to say, and we will need to fight all together against some trends that I would like to mention in a minute. Well, the first thing is on the positive side, you've got at this point in time more than 150 vaccines being developed. 29 are in the clinical stage, 140 are in the preclinical stage, and of the 29 that are the most advanced, you have 6 that are in phase 3, 1 from Moderna, 1 from Pfizer, 1 from Sanofi, 1 from AstraZeneca, and 2 from Chinese state-owned enterprise. Very different platforms of manufacturing, viral vector, RNA, protein subunit. So very, very different manufacturing challenges associated with those vaccines. All of them, I mean the 6 that are in phase 3, are currently in the process of recruiting very, very large cohorts of patients in the dozens of thousands of patients in geographies like Brazil, India, the UK, most notably. And that's for the good news, because it's quite unprecedented that vaccines would advance the clinical pathway so fast. And just referring to Moderna, that is a partner of the forum, it took Moderna 63 days before they get access to the DNA of the virus, to the moment in time where they engaged into clinical phase 1, which is really unprecedented. 63 days has never been heard before of. So that's for the good news. On the less good news side, you need to know that 2.5 doses from those 6 manufacturers I was mentioning before have already been pledged to high-income countries in contracts with governments like BARDA or the European Commission or Japan or the UK. So 2.5 billion doses being pledged to high-income countries. And I would like to plant another number in your minds. The total vaccine manufacturing volume last year was 3.5 billion doses, mostly so in the diphtheria, tuberculosis, and measles and polio. So you can immediately recognize that there will be a huge manufacturing challenge if the manufacturing capacity, mostly so in emerging countries, is being pledged in support of those government contracts. And as a result, we are left with no manufacturing capacity for low-income countries, which is a huge problem. By way of comparison, I would like to mention that only 300 million doses, to be compared with the 2.5 billion, have been at this point in time being pledged via FACP to low-income countries, and that was a particular contract with AstraZeneca. So challenges will be threefold. I mean, the first one, obviously, the clinical trial pathway is such that there is still a lot to be proven in terms of safety, immunogenicity, tolerability, and frankly speaking, duration of the protection of those vaccines when they come to populations. The other thing that we will need to recognize is that those vaccines will probably be made available in very large quantities pre-licensing. Meaning that if you look at the protocol of the trials at this point in time, many have endpoints after 1 year or 2 years to demonstrate that the protection is still present in humans, meaning that we won't know for sure about the duration of the protection at the time we start vaccinating populations. There will be also mostly 2 doses vaccines, which is going to represent its own set of logistical issues. And some of them will need a very, very robust cold chain, in particular when it comes to RNA-based vaccines. So one of the issues will be about the liability to manufacturers of getting to populations vaccines that are unlicensed, and what's going to be the immunity regime for those manufacturers in case some populations declare side effects that are unknown at the time vaccinations campaigns are being launched, not to even mention the trust in vaccine issues that will be a huge problem if accelerated pathway of clinical trials are going to cast a doubt in the minds of population on the clinical scientific base for vaccines to be delivered. So at the forum, I think our main objective at this point in time is to support the COVAX facilities that is being run by CEPI and Gavi. That is an instrument that is trying to raise close to $20 billion in new money to actually commit to advance purchase commitments to manufacturers at scale in support of low-income countries, and additionally to try and create a network of manufacturers from India, Korea, Brazil, and South Africa that would actually receive grants and funding, possibly from the IFC, to actually scale up the manufacturing capacity, not limited to filling and finish, but including filling and finish. We think the 2 instruments, I mean, the advanced purchase commitment and the manufacturing alliance, are going to be fundamental in helping populations to get vaccine at scale. But we also believe that even in that context, it's very unlikely that vaccination campaigns globally will end before another 3 years. Over.
Your perspective is greatly appreciated. Thank you. Amesh, have you been able to join us?
Yeah, I'm here.
Great. As the primary author of the Johns Hopkins Center for Health Security report on characteristics of pandemic pathogens, I'd be very interested in knowing what you see as the potential for future pandemics, what you think we can learn from this COVID-19 pandemic, and what should we have learned from the H1N1?
So it's not a question of whether or not we're going to see more pandemics. This is going to be a simple fact, because you have a world with billions of people that are very well connected, the rise of megacities, and we're only scratching on the surface when it comes to pathogens that can infect humans. And we do a very job even with those pathogens. How many times have you heard about somebody getting diagnosed with a pneumonia, but not knowing what type of pneumonia it was, what bacteria caused it, what virus caused it? And lurking within those could be the first forays of a new pathogen into humans. And if you look indeed at COVID-19, it was described as an atypical pneumonia first before we actually realized it was caused by a novel virus. So I do think the issue of pandemics occurring in the future is one that we're going to have to face. And I think it will probably be sooner rather than later. There are many pandemic viruses out there. For example, we have a new swine flu virus circulating in China. We have avian influenza. We have other coronaviruses. Hendra virus, Nipah virus. A lot of these viruses have this pandemic capacity because they have this ability to cause virulent disease. They have the ability in certain circumstances to spread between humans, some less efficiently than others, but we always worry about them becoming more efficient, like avian influenza. And we have very few tools to fight them. And we can see what happened with this coronavirus pandemic with something that has probably a true case fatality ratio of less than 1%, disrupted the entire world and led to countless deaths. So that really makes you think that we're not very well prepared for any kind of pandemic, even one that is as less severe as the COVID-19 virus compared to what we're looking at, for example, with avian influenza, where you have case fatality ratios of 30% or 60%. Those would be cataclysmic with the current apparatus that we have. When it comes to these viruses, you have to remember that in the past, the era of epidemics was much more limited because travel was so different. A virus would spread basically at the speed of a steamship, and the incubation periods were such that people would get sick overseas as they're over the ocean, and they would either die or recover, and you didn't have importation of disease from one part of the world to another. Now, pathogens spread at the speed of a jet. So you can have an outbreak in one part of the country, or one part of the world affecting the other part of the world within 24 hours. So this is a fact of the world that we live in. So we have to get much more serious about pandemics. When you go back to 2009 H1N1, I think a lot of people have forgotten about this, and I was in training when that happened, so it's really seared into my memory, and I had just started in the field of biosecurity and emerging infectious diseases. And this was a virus that emerged. So at that time, what we learned from 2009 H1N1 is a whole bunch of different lessons. First, at that time, people were really looking for the next flu pandemic to emerge from China. So no one expected the virus to emerge from Mexico. So there was all of these plans based on the United States having a major lead time to be able to, for example, respond with contact tracing, with all kinds of different elements. But those were out the window, because what happened was in April of 2019, we found 2 girls that got infected with this virus in Southern California. And we know with flu viruses, because this biology has been well characterized, that when you're catching a case, that's really the tip of the iceberg, because this virus spreads so efficiently, and it unequivocally spreads when people are not symptomatic. So the day before you have symptoms, you're contagious. So we knew right away that this was going to be a virus that was going to engulf the United States, and thinking about trying to contain it was really futile. But what we needed to do was get hospitals ready, a vaccination program ready, and I think there's a couple of lessons to learn there. One was initially there was some panic because we were getting what are called the skewed examples of how severe it was from Mexico, because that happens all the time during the fog of a pandemic, that you first hear about cases that are in the hospital, that are in the ICU, that are making the headlines. You don't hear about all the mild cases. So initially we thought this was going to be a pretty severe flu strain. Eventually we found out, though, that this flu strain in 2009 was less severe than our seasonal flu. And that really took the panic level down a lot. And we got to thinking about how we were going to live with this virus. And it's different for the COVID-19 virus because it does have a higher case fatality ratio than seasonal flu, and it is extremely deadly in certain age groups. So just a couple of some things about 2009 was we had a problem with the vaccine in the sense that it was hard to grow, it was not the easiest vaccine to make, and then the way the allocation system occurred was constructed basically left it to states, and states were allocating kind of using kind of a calculus that nobody quite understood who was getting the vaccine and who wasn't. People weren't sure when the shipments were going to arrive. I remember I was working at a tertiary care medical center in Pittsburgh where we had lots of cases, but we were one of the last hospitals to get the vaccine because it was such a big order. I ended up getting my vaccine after the peak in November at a school where I had to just stand in line and get my vaccine with everybody else that was part of that priority group. So this is an important lesson to learn as we think about vaccine development, that you have to really think about how you're going to get the vaccine into the arms of people. Making it isn't the whole, isn't everything. There's a lot of distribution that we have to think about. And a couple of other last points. So I do think that we're going to face a pandemic, but the way that we prepare for this is to get ourselves out of this cycle of neglect and panic that continually characterizes pandemic preparedness. And when things are in the headlines, everybody's interested in pandemics, everybody's thinking about spending and funding, but as things fall out of the headlines, people stop worrying about it. So that happened with SARS, that happened with Zika, that happened with H1N1, and avian flu, with anthrax, every infectious disease threats. Things, as they recede from the headlines, as the media turns their attention to something else, so do the politicians and policymakers. And that's why we're vulnerable. That's why this pandemic didn't have to be. 17 years after SARS, we had no coronavirus countermeasures, no coronavirus vaccines. Why is that? It's because we go through this cycle of panic and neglect, and we cannot do that. And I think that organizations like the World Economic Forum are great avenues to get preparedness at the top of people's agenda, at the top of leaders of all of these countries. World leaders pay attention to what the World Economic Forum suggests. And I do think their endeavors like Gavi and CEPI have really made us much more resilient, but there's so much more work to do. And I do think that we have now, because of this pandemic, touching every person on the planet, a real concretization of what a pandemic can do and what economic losses and economic disruptions and loss of life really looks like, and why it's so much easier to prepare for these than actually to respond for them. So I do think we do have this window of opportunity now to fix some of these systems and decrease the risk from pandemics, but it is a very hard challenge because people do not prioritize things or think long range when it comes to infectious disease emergencies.
Very well said, Amesh. And I think that's one of the real strengths of this particular panel, is bringing in this global perspective, because this is not a problem facing any one country or any one profession. And with that, Stanley, I'd like to turn the question to you. I'd like for you to discuss some of the public-private partnership issues and supply chain lessons that we may have learned, and how we can improve these in preparation for the future. And you've had a long-standing relationship with this organization, OSAP. And in the context of public-private partnerships, why do you feel that the work of OSAP is important, and what would you see OSAP doing in the future?
Good morning, everyone. Don, thank you for the role you have played as a public servant, and in particular in the area of public health. Marguerite, decades of focus on infection control. You are dedicated to this part of dentistry. Thank you. Of course, Arnaud, it's great to see you. The World Economic Forum is the world's greatest public-private platform. The healthcare component of the World Economic Forum is critical. You lead that. And Amesh, what can I say about you? You have your finger on the pulse on public health and pandemics and viruses, and have been of help to so many organizations throughout the world. So let me just pick up from what Amesh said, and let me put it quite bluntly. Epidemics, pandemics do not have passports. No one country is insulated from such a challenge, such a problem. And if we don't deal with this on a global basis, and I think Arnaud mentioned that the vaccine will only go really to a part of the world. I think if we don't work on this as a global issue and countries don't collaborate and cooperate, we are going to really have problems that is going to continue to affect each one of us. The second, and yes, vaccines are critical. And when they come, that's great. Treatment is important if there is no vaccine. But what is really, really, really critical is prevention, infection control prevention. This is what OSAP has done for the dental world since the early part of the 1980s, when it was alleged for the first time that a patient passed on AIDS to a dentist. OSAP became the perfect public-private partnership to address infection control in the dental arena, to the point where I think dentists as a profession are way ahead of many others in healthcare in infection control and prevention. Now, to give a little bit of a perspective on the challenge relative to prevention in healthcare as it relates to epidemics, pandemics. We had a perfect storm in February of 2020. Just before that time, the leading manufacturer of gowns had a challenge with the FDA, and their product was pulled off the market going in to the Chinese New Year, when, of course, a huge part of the world's PPE comes from China. So there was already a shortage of gowns, a key component parts, and related products in the PPP world. Then what happened is the corona virus started becoming a global issue at a time when the factories were just coming back from work to work, the employees, the workers, the factories for this PPE products, particularly masks, leading to, and there's a lot more behind it, a global shortage, which was accentuated by certain governments around the world. And these governments are all over the world putting in restrictions and creating a panic, and certain governments jumping in and bidding up the price of these products, making it very difficult for the normal supply chain to work. So, let me talk about public-private partnerships in this context. First, I mentioned OSAP. OSAP prepared dentistry for infection control, no question, and has done a great job. Michelle, you and your organization, good job. At the World Economic Forum in 2015, we formed the Pandemic Supply Chain Network. This was a group of businesses, Becton Dickinson, BD, J&J, UPS, Henry Schein, and 60 other manufacturers, private sector components involved in planning the supply chain for pandemic planning. We worked with the World Food Program, the logistics arm for the UN, the World Health Organization, the World Bank, the CDC, and governments throughout the world. The World Economic Forum gave us that platform, as they did for Gavi and for CEPI. Then, and this, the goal of this private sector, the Pandemic Supply Chain Network, was to ensure that should there be an epidemic or pandemic again, we would not be exchanging business cards for the first time, but knew who was involved, where product was. And I can assure you, with all the challenges we had in PPE, if this group had not been in place, the challenges would have been much worse. The UN Supply Chain Task Force dealing with PPE has played a critical role. Maybe not so much in the US, but PPE is needed throughout the world and helped. When it comes to the United States, there's a lot that went wrong, the management of this pandemic. Let's not talk about that now. The history books will explore this, public health people like Amesh and others will write about this for decades to come. But the one area that really worked well, and fortunately, we, Henry Schein, myself personally, had ringside seats. And that was the Fema task force, some call it the Fema White House task force on COVID-19, focused on prioritizing the distribution of what was a limited availability of product in March, April, and May, a little bit better in June, and a little bit better in July. And in that context, we were able to advance dentistry from a fourth priority up to the top. The partnership also drove the Project Airbridge. Lots and lots of misunderstanding. Basically, what Project Airbridge did was provide a vehicle, just like the Berlin airlift, to bring product from China that was FDA approved into the private channels in the United States for distribution to the public sector and into the private sector. An unbelievable, true public-private partnership that had this not happened, we would be even in deeper challenge situation with PPE. The key thing that the task force did was not only prioritize from a professional point of view, which profession should go first, but also the hotspots and where product was needed rapidly, and that was very, very volatile. I can assure you of one thing, that had there not been this public-private partnership with competitors saying, you know what, we're going to work in the interest of the people of the United States, we would be in a different place today. And I want to tip my hat to the Fema people. These are devoted professionals supported by military personnel that care about nothing else other than the well-being of the people of the United States. These kinds of programs were implemented in other parts of the world. Public-private partnerships played a key role in digging out, not completely digging out, but digging out from a very challenged situation as a result of the prevention that PPE plays in the whole COVID environment. So I can say nothing but it is critical that public-private partnerships drive pandemic planning, drive epidemic planning, and in that context, welcome the work of OSAP, welcome the work of groups like the Fema White House Task Force, and of course, on a global scale, the World Economic Forum. Thank you, Don.
Thank you, Stanley. Another question for the panel in general. What changes would you anticipate in healthcare in the future as a result of this pandemic? And I'm not talking just about care delivery changes, because we've talked here public-private partnerships, the integration of healthcare and policy. I'd be very curious as you look into the future, what you would see. Anyone care to start off?
I think that there's a couple of things. Definitely care delivery, which you don't want to talk about, but that definitely is going to change with telemedicine and other types of modifications. But I do think that hospital preparedness, pandemic preparedness, thinking about supply chains are if there was a major patient surge. And there are some hospitals that are really aggressive at doing this and think proactively about this, but many are very reactive. And I don't think that that's going to be the case anymore, that this is going to be much more part of emergency planning in hospitals. Many hospitals in the United States, for example, their emergency planning consists of thinking of mass casualty accidents, like a mass shooting or something, which unfortunately is common in the United States, but not something that has complete relevance to pandemic planning, because pandemic planning is something that's going to be sustained, and the personal protective equipment needs are going to be over time, and staffing needs are going to be over time. So I do think that this is going to be something that does change, that people are going to really try and figure out how to solve this problem, because you have to think, we're doing this on Zoom right now. And when the pandemic started, Zoom immediately increased its capacity, but our healthcare system didn't increase its capacity. They were unable to do so in a very quick manner, because beds need to be licensed. You have to get approvals. Your competitors have to decide whether or not there actually is a need for increased capacity. All of that, I think, is going to call into question the way we think about healthcare delivery and this running near capacity all the time, because this really exposed that that problem. If you'd went to a New York City hospital 3 years ago, it would have probably been near capacity as well. There just isn't room to take care of any kind of major surge. And I think that's something that really needs to be addressed and should be changed moving forward.
Yeah, I think there is an immediate opportunity, considering the type of scientific progress that has been delivered over the past decades, to actually fundamentally revisit our surveillance network and alert mechanisms. And you know, there was this article by David Cameron, the former Prime Minister of the UK, and he said something like, you know, if every time we need to rely on a country taking 1 month to tell WHO and then WHO taking another month to tell the world, we are going to lose all those battles. Ironically, this virus is known for decades. I mean, it's a very well understood, very well known zoonotic disease. If you think about creating a large network of, say, 200 or 250 sentinel hospitals distributed in a logical fashion across the globe, including in low-income countries, and equip those emergency departments with next-generation sequencing equipment in a way such that the samples can be compared very rapidly to existing registries of zoonotic disease, you could actually shortcut the alert system and shortcut the time to react by arguably 2 months, and do that in a fashion that is apolitical, does not need to rely on WHO, does not need to rely on any country, and would be basically in the hands of medical professionals.
Excellent. Stanley.
Yes, so of course I agree with both points. The supply chain has to be prepared for much more scientifically and in a less haphazard way. And of course, the collaboration that Arnaud is speaking about is critical. But I want to talk about something that is going to impact leadership, and particularly in business, in the future. And therefore, indirectly, but in a very direct way, on healthcare. And that relates to the notion that moral leadership from leaders in every sector has driven up the importance chain. Of course, from a business point of view, this was highlighted by Larry Fink from BlackRock a year ago, maybe, Jamie Dimon from JP Morgan, the whole idea of stakeholder capitalism, something that many of us have practiced. Our Henry Schein business is based on the notion of the 5 constituents: our suppliers, our customers, our team, investors, and society that drive our business. But I think what has happened, a healthcare crisis turned into an economic crisis, and in many parts of the world has turned into a morality crisis. In the United States, of course, the George Floyd sad situation brought a whole bunch of matters to the top of the agenda, but also the mortality rates amongst different populations in the United States is astounding many. That will have a profound impact. The fact that trust is at a low, and the Edelman Index, and I would recommend participants take a look at that. It's a report published at the World Economic Forum every January, points to something that is very interesting. The only area where trust seems to be stabilized and going up is employees trusting employers. What does that mean? Employees expect leadership of companies, of universities, of public health institutions to be speaking about the morality issues of the day. So I think as we emerge from this crisis, and I happen to agree with Amesh, this is not the end of epidemics and pandemics. This is going to continue. As we emerge, it will become very clear that the business of business is no longer going to be strictly business. Yes, it will be business, but will be to drive that institution towards the general interest of society. And in that context, I believe healthcare will advance, but I believe that only those companies that understand that profit is one of 5 elements. Yes, you've got to return a good investment, return to your investors, but only 1/5 of the story is that. The others are the other constituents, and those other constituents in balance will drive the success of the company. And I believe that the millennials are going to drive this. I believe they're up to the challenge. There are so many challenges in the world today, and I believe the millennial generation are up to the challenge of advancing the public needs of all of us, including that of business. And of course, business is the place where jobs are created. So if business is not successful, jobs will not be created, but in the context of the needs of society.
Thank you, Stanley. That is profound thinking. The integration between business and public health, I think, is one that's critical. In looking at it from the healthcare perspective, most of the people here are oral health people. And I'm curious what role you would see as oral health as a profession, as an entity, in strengthening the healthcare system that we have in the US and in global. And what's that relationship? Because there's often a significant disconnect there.
So Don, so go ahead.
Yeah, Stanley.
Yeah, so Don, this is not the place to talk about the direct correlation between good oral care and good health care. There are many other forums in dentistry that undertake this. But it is critical. Good oral care and the whole body go hand in hand. And it's very interesting. Even in the midst of all this crisis, the Fema team understood that dentists that are triaging patients from going into the hospital have a key role to play, not only in the context of preventing people that are very sick from getting sicker, but in prevention in general. And it's in this context, actually, that I would like to talk about the World Health Organization report that was published yesterday. The report in general is correct. What it says is, do not go to a dentist who has not been trained in infection control. That's what OSAP is all about. And yes, it is critical that dentists be trained in the use of PPE, in the use of legitimate PPE, regulated PPE. At the same time, if dentists are trained and hygienists and other healthcare professionals, but they don't have access to PPE, you can't go to the dentist. And so I think that report was slightly misunderstood. And the misunderstanding is that, yes, dentists need to be trained, and yes, dentists need to be given access to PPE. And where that is the case, I personally agree with the report that people can go to the dentist because dentists are exceptionally careful about infection control going back to the 80s during the HIV emergence. And at the second point, and the corollary to that is if you don't have PPE, you should not see a dentist, which leads me to the moral dilemma that we in the developed world have to ensure that those who cannot access PPE, whether it is in the United States, there are communities today that cannot access PPE, and there are countries that cannot access PPE. We have an obligation to ensure that access to PPE by providers of services in these countries, in these communities, access PPE. So, bottom line is, oral care is critical. And if we don't provide the infection control products to dentists and oral hygiene providers, we put the public at risk, and we have an obligation to ensure that there's training and delivery of PPE to everyone, rich and poor.
Excellent. Amesh, you were going to say something.
I agree with all of those points. I think it is really important to think that oral health is part of medical care. And I think that there's often this dichotomy that's not really there. And I think of dentists and other oral health professionals as part of the team of healthcare professionals. And I think that it's people don't realize that people still have dental emergencies and have dental needs during a pandemic. And if they don't get it from their dentist, they end up coming to the emergency department where there are little resources to actually be able to intervene. So I do think that if you're talking about hospital capacities and keeping our ERs free to take care of COVID patients, you have to allow dentists to be able to practice when they're appropriately trained and have the appropriate personal protective equipment, because those dental emergencies don't cease happening during a pandemic. And I think this was a mistake that was made in many places where they didn't have dentist office open, that some governors may not have allowed that to happen. And I think that was the wrong decision to make. And I've been talking about that from the beginning of the pandemic, that we can't trade one. We have to think long term about this. We can't just look at COVID-19 and not think about all the other health consequences. And this is the same with cancer screenings and vaccinations. All of that went down, and we'll pay the price for that. So I think we need to get better about thinking about these things in a much more long range, full context approach.
Arnaud, from a global perspective at the World Economic Forum.
Yeah, I think three areas of comments. I mean, point number one, the definition of healthcare workers. When we talk about the 46 million that need to be prioritized when it comes to having access to vaccines, the first population to be vaccinated when there is a safe and effective vaccine, I think we should make it extremely clear that the dental profession is absolutely included in the definition of healthcare workers. And we are not only talking about primary care physician and hospital workers. Point number two, I have to believe that when there is going to be an antigen test that is going to be sufficiently reliable, a lateral flow test like pregnancy test type of things that provide an answer in matters of minutes, I think I would strongly suggest that it becomes a tool that is widely used by the dental profession. And last but not least, and it has been mentioned before, this is holistic care. I think we've seen those dramatic situations in Wisconsin where 5% of the population is of an African American descent, and represent 50% of the fatality for the state. I think this is the same population that is having no access to dental care, and we know that the consequences are very well documented when it comes to cardiovascular disorders. So I think a call to action to address the social determinants of health and consider the dental prevention, dental care as part of a prevention toolkit is an opportunity as we speak.
A question about surveillance. You mentioned the importance of surveillance, and here we are 6-7 months into this pandemic, and there's clearly no national or global surveillance system for COVID-19. Interested how you think we would go about developing a surveillance system that's not only community-based and population-based, but population-specific to things like individual healthcare worker groups. We have no real good data on the risks faced by oral health professionals, for example, and what is the risk of transmission in various settings. Any thoughts from anyone on that?
I would ask Amesh, that's really up his alley.
So I do think it is important to do this type of surveillance. We know healthcare workers of all sorts are more likely to get infected than the general public because of their the fact that they're essential workers, so they're out and about, as well as the fact that they're taking care of patients that are infected. I think that we've had an utter failure in the United States to develop any kind of testing strategy, and it's been very haphazard and varies from state to state. And I do think it has to do with early mistakes that were made in January, February, and March about what this virus represented, and developing the testing capacity. And in the private sector, it was basically the private sector was not able to really engage for a significant period of time, and we're still paying that cost. So I do think it is important to look at antibody studies in healthcare workers, including in dental workers, to try and understand what the transmission, what transmission has been to dental workers, and then also just really, the only way we move forward is having this basic question answered: who is infected and who is not? And we still can't answer that question in many parts of the country. We don't, and that's the whole reason we have this pandemic the way it's gone, is that we still have people that are out there infecting other people that don't know they're infected, because we don't have a cheap, easy test, nothing even close to a lateral flow test, although people are advocating for that. And until we get to that position where we can know your status for coronavirus the way we can know our status for HIV in the privacy of our own home even. That's something that we're going to continue to face. And I do think this is one of the biggest lessons, is that no matter how great our planning is, if we can't diagnose people, you're really going to have a pandemic that runs out of control. And you could have predicted this would happen if you take diagnostic testing and give us the diagnostic testing problems we've had. It's not a surprise that the United States is kind of at the lowest level of the pack of countries dealing with this virus.
Any other comments or thoughts?
No, I fully concur with what Amesh is saying, but we need to also realize that the industry will have to step up their efforts when it comes to improving the type of diagnostics we are having at this point in time. There is no way on earth we can provide diagnostics to 500 million tests in low-income countries like it is arguably necessary based on PCR. It's not going to happen. So we need a reliable antigen test very, very rapidly, and preferably one that is instrument free. And that's going to be one of the key bottlenecks to surveillance programs.
So Don, let me just pick up from what Arnaud said and Amesh. And I only want to deal with the US today. And I'm not a healthcare public policy expert, but I come to it from a different angle. And that is, we are a significant provider of point-of-care tests to physicians. In my view, rapid point-of-care tests, antibodies, antigen, is significantly lacking. We do not yet have the capacity. We have machines that do it, products that can be used in complex laboratories, but we have not driven the process to where the point of care takes place, which is the physician's office and arguably the dentist's office. There are 100,000 dental practices or so in this country. Dentists can play the role. There's no reason why not. Public health protocol is ready. Dentists are ready. Physicians are ready. The product is not being made available. What is being made available is tests by large labs, some equipment in moderate amounts that use reagents, but the quick pinprick test has not been approved. It's been used in countries like Korea very successfully, in China, in Hong Kong, in other parts of the world. We have not gotten there yet. And of course, there probably are very good reasons for that, but it's worked successfully in other countries.
You know, the social upheaval, economic upheaval, and impact on the healthcare of the population of the globe has never been impacted in our lifetimes by something as impactful as this COVID crisis. And I think moving forward, we're hearing a consistent message that this is not likely to be the last pandemic. As this session comes to a close, what would be one final thought that each of you would like for this audience to consider in anticipating a post-pandemic healthcare system? And by healthcare system, I'm not talking about just the care delivery, but that integration between business, public-private, public health, and clinical services. What thought would you like to leave for this audience to consider? Does anyone want to start this? Arnaud, we started the session with you. Why don't we see what your thoughts would be on this?
Yeah, I think like in every crisis, there is a silver lining, and Amesh mentioned already that we have seen telemedicine, telehealth, EICU, teleradiology accelerate by decades in the period of the crisis, and that's not only a question of the convenience factor. It's also because people are going to increasingly resist going to hospitals for very benign symptoms. And I would my dream, in a way, my hope is that the regulatory and the payment systems are going to evolve in a fashion where those procedures are going to be better recognized as they have been paid for during the crisis. There are current debates about how the payment is going to evolve post-crisis, and I hope the debate will land in the right place.
Well said. Amesh.
So I think that the biggest, I echo exactly what Arnaud said, that there's going to be definitely changes in medicine and delivery that occur. But I also think there's going to be much more integration of public health and healthcare delivery. I think that people realize that we need to have early warning systems, that everybody has to be invested in public health, no matter what your specialty is, because there are going to be infectious disease emergencies that have these cascading impacts on all types of healthcare. So I think that people are going to learn more how important it is to support public health, to support public health agencies, and have kind of a two-way communication so that things happen quickly, because we're seeing right now what the consequences of not having an integrated public health system are. So I do think that that's one thing that's going to happen. I think there's going to be, it's very hard. Pandemics, any kind of infectious disease emergency, going back to the Black Death, leads to lots of different changes in society. And I think we're going to see myriad changes. Some of them we can't even predict right now, because this was such a disruptive event. So many things got changed and had to change direction, that it's really going to be hard. And it will be actually something for scholars to do, is look how the pandemic changed everything. But I do think it's going to be different. It's not going to be the same thing as it was in 2019 when we get to 2021 or after the pandemic. And I think we have to be prepared for a lot of adaptation to a new normal.
Stanley.
So, of course, I agree with Amesh and I agree with Arnaud. I would just like to focus a little bit on one area, and that is the supply chain for PPE and testing. I would say these are the least, certainly the supply chain for PPE is the least sophisticated part. It's not as complex as bringing out a new vaccine or coming out with a treatment, but it is not treated with respect. And if governments around the world don't treat the supply chain for PPE with respect, we will never get through these challenges, because we'll have the flare-ups and they will get out of control. We can keep these flare-ups under control with simple devices like a mask, a cleaning solution made available. And please remember that viruses do not have passports. So the flare-up may occur in some remote, probably healthcare bankrupt part of the world. We can't say, wow, that's a remote part of the world. It doesn't impact us. We don't care. We have to care. We have to stop the pandemic becoming a pandemic, the epidemic becoming an epidemic at the source, by ensuring we have PPE at the right place at the right time. And in that context, this will require global collaboration, because right now, the world is still dependent and is likely to be dependent on a few countries for masks, for gloves. These are not easy devices just to move around. We need an understanding that the supply chain will be treated with respect, product will be made available, countries will allow product to move. The wealthy countries will not buy up all the supply so that the poor countries don't get access to it, because if the poor countries don't get access to it, that virus is not going to be stopped in the poor country. So it's a morality issue, but from an enlightened self-interest point of view, it is critical to make sure that the supply chain for PPE is working globally. So the work that CEPI and Gavi do for vaccines is as important in PPE and testing. And so, Arnaud, I thank you, particularly the World Economic Forum, for giving us the platform to start the pandemic supply chain network. But I would ask that this be an initiative where we engage governments around the world and business, not only the 60 companies that are involved, but companies around the world and governments around the world, so we can ensure that the next time we need masks or gloves in some remote part of the world, it gets there right away, together with the soap and the cleaning solution that can stop this infection from spreading.
Well said. Arnaud, would you care to respond?
I fully agree, yes, Stan. I think we have done a lot of progress with PSCN. It has been a fantastic instrument, fully leveraged by WHO, but I think we need to do more. I think there is also an opportunity to also build on that platform to actually build that IT instrument that would be a matchmaking instrument between supply and demand. And no one has built that. And I think this is one of the opportunities that we would like to work with you on moving forward.
Good. Yeah, Stanley, I'm curious, do you see a place for OSAP at the table as we have these global macro discussions about pandemic preparedness and supply chain?
Yes. Thank you for asking, Don. OSAP has the technical and clinical information. Unfortunately, it's only known to the membership of OSAP. It's a good membership, represents most of the industry. A lot of the public health people, if not all, in oral care are involved. And yes, academics are involved. But we need to make sure that governments, the global network, understands what OSAP has. And OSAP has the key to information on infection control in oral care, but the same infection control protocols apply to physician officers and any other healthcare worker environment, EMT, etc. It is unfortunately a very well-kept secret. Yes, those are directly involved with OSAP know what OSAP does, but we need to get the word out, and we need to get funding from more than just the dental arena to get that word out, because OSAP has the information and has the participants that understand how to prevent a pandemic rather than only treat the pandemic afterwards.
Stanley, thank you for those words. I'd like to extend my most sincere thanks to this panel. I've been participating in this organization for many decades, and this was one of the most stimulating and thought-provoking discussions that I've been able to participate in. And I appreciate the time that the three of you have given to this, the expertise that you've given to this, and more importantly, to the work that you've done to alleviate the pain and suffering as a result of COVID and other infectious diseases. On behalf of OSAP and personally, thank you.
Thanks to you. Thank you, Arnaud. Thank you, Amesh.
Thank you all. We are honored that you were willing to give up your time. You are all very busy. We appreciate it. Your insights today were absolutely incredible, on point. And I have to say that I'm very thankful. This is one of the recorded sessions. I will probably listen to this again and again. I think it's one of those sessions, the more you listen, the more ahas that will come out.